Six, seven. I was like, oh, you got my number. Okay.
You're gonna cover me by answering a regulatory call? Get that
Little nice.
I don't know. This is good.
They're magnesium.
Oh, no.
Does that go?
When I was on night flow, I was like ambulatory call like or something, and I'm like, I don't know what's wrong with your eye, but it sounds like you'd like to see somebody. And I know.
Sunday night.
It's not.
So it's semi. When the keeper or us came in. That's semi. Yeah. So that was like 11 p.m. So the cath lab was activated. They go for it. Yeah. Yes. No. That was this is the before. 11. Yeah. Alex came. I don't have a comment, right? Came. And then the case was complicated because it was like, because the patient was pretty genetic, like that, color and all that. So everything's finished at 2 around a little after 2. So they, and at 2:30, like 10 minutes after the Alex left, was another semi. Like and he came back, he stayed until like 5 a.m. Yes, you had to move. Working like 40 hours.
Machine. Yeah.
Sam Elliott, hey. Nice to meet you. I'm so glad you could be here. I've always wanted to bring my wife to Grand Rapids. She's always
With it 3 times.
I hear about this enough.
I gave pulmonary.
She works here, right?
She works.
I was like, he was like, oh, I should probably find my way. I was like, I don't know how to give directions here. And then he like found it on back path.
That's so cool. Nice to meet you.
That's what I think.
I know. And my ideas.
We usually make it.
The window with.
You look.
Wow.
And are we waiting on it? No, I think we should go ahead and get started, I guess. It's 5 o'clock, right? All right, are you unmuting?
Sounds like it. So this gentleman needs no introduction. Easily in the top 2 best Hopkins recruits that Yale has ever seen. Dr. Ani Shahu has been bouncing back and forth from Hopkins and Yale. Hopkins undergrad, Yale Medical School, back down to Hopkins, back up here. Then back down to Hopkins for a chief residence or resident fellowship, and then coming back up to us. He's going to do critical care next year at Columbia, and it's just simply one of the kindest, smartest people I've met, and hopefully we can recruit him back. So thanks for the honor of introducing you.
All right, everyone, thanks for coming today. So I'm going to be talking about the past, present, and future of percutaneous microaxial flow pumps. I don't have any disclosures. Our objectives today are to review the history and indications for the use of percutaneous transvalvular microaxial flow pumps in patients with cardiovascular disease, to review existing evidence, including randomized clinical trials supporting the use of percutaneous microaxial flow pumps, and to discuss new developments and future directions in the use of these devices. Greater than 5% of patients with acute myocardial infarction develop cardiogenic shock. These patients experience significant morbidity with mortality approaching 40 to 50% despite the advent of early revascularization, advancements in medical therapy, and the use of intra-aortic balloon pump counterpulsation. This problem was highlighted in the shock trial in 1999, which showed that early revascularization in patients with acute MI and cardiogenic shock did not improve 30-day mortality. Additional mechanical circulatory support devices meant to provide temporary hemodynamic support to patients with cardiogenic shock were created. And one increasingly popular form of support is the transvalvular microaxial flow pump. The most well-known example of this being the Impella device. The first microaxial flow pump and forerunner to the Impella was called the hemopump. A 7-inch inflow cannula was placed in the left ventricle, was connected to an axial flow pump, and the outlet cannula was placed in the ascending aorta. Maximum speed was 2,700 RPM, providing up to 3 to 4 liters per minute of flow. And a 1988 study showed that left ventricular unloading with the device improved myocardial perfusion. A major drawback here that limited its use was that the device could only be placed surgically and use an external motor. The next generation of microaxial flow pump, the Impella, was first produced in the 90s and improved upon the hemopump design with an intracorporeal motor that could be implanted percutaneously. The Impella contained a miniature rotary blood pump that could rotate up to 32,000 times per minute with flows up to 4 liters a minute. And the device aspirated blood from the left ventricular cavity and expelled it into the ascending aorta. It contained a pressure sensor that registered the difference between the outflow and the inflow cannula in the LV to determine correct pump position, and most importantly, it could be placed percutaneously via the femoral artery. Placement of a microaxial flow pump was shown to be feasible in humans in a 2002 study of patients undergoing CABG. The patients were randomized to an intracardiac pump group that received, dual left and right intracardiac microaxial support pumps. The control group underwent typical normothermic cardiopulmonary bypass. There were no significant differences in the clinical outcomes, including 30-day mortality and major adverse outcomes. And there appeared to be lower inflammatory response in the ICP group. A follow-up animal study examined the impact of Impella use on infarct size. MI was induced by occluding the LAD for 60 minutes, followed by 120 minutes of reperfusion in 26 sheep. The animals were divided into 4 groups. Group 1 had no support, Group 2 was fully supported with a pump during ischemia and reperfusion, Group 3 was supported during reperfusion only, and Group 4 was partially supported during reperfusion. The Impella was placed surgically via a cut down in the carotid artery, and infarct size and several hemodynamic parameters were studied. Impella significantly increased diastolic and mean blood pressure and significantly decreased LVDP, and resulted in higher myocardial flow during reperfusion. There was also reduced myocardial oxygen consumption during ischemia, and in the figure, the black bars indicate the infarct size, which was measured to be the smallest in Group 2, which was the one that was fully supported during ischemia and reperfusion. The first randomized clinical trial in humans to evaluate the feasibility, safety, and efficacy of Impella for the indication of cardiogenic shock due to acute MI was the ISAR shock trial published in 2008. It enrolled 26 patients with acute MI complicated by cardiogenic shock who underwent PCI and randomized them to either balloon pump or Impella 2.5. The primary outcome was change in cardiac index from baseline to 30 minutes after implantation. The main finding here was that the change in cardiac index was significantly higher in the Impella group at 30 minutes after implantation, but not significantly different between the 2 groups thereafter. Cardiac index in the Impella group increased from 1.7 to 2.2, while in the balloon pump group, cardiac index increased only from 1.7 to 1.8. Hemolysis was also higher in the Impella group, and there were no significant differences in the other secondary outcomes, including 30-day mortality. Limitations for this included the small sample size and the early time point for primary endpoint assessment. And then finally, the timing of intervention and the timing of device removal were at the discretion of the physician. The findings from ISAR shock, though limited, directly contributed to the FDA approval of Impella 2.5 in 2008. It required a 13 French sheath to be placed either in the femoral artery or the axillary artery, and it provided flows up to 2.5 liters per minute. It was approved for use up to 6 hours for high-risk PCI and up to 4 days for cardiogenic shock. FDA approval of the 2.5 then led to the development and approval of the CP, the 5.0, and the 5.5. And there are a number of contraindications to placing the device, the most important ones being left ventricular thrombus, mechanical aortic valve, and severe aortic valve disease. Currently, the Impella CP and the Impella 5.5 are the only devices that are being used. So the Impella CP is similar to the 2.5, but it requires a 14 French introducer sheath and offers more support with flows up to 4 liters a minute. It has an inlet, outlet, and flexible pigtail, as you can see in the middle picture. And the Impella 5.5 is only approved for use in cardiogenic shock. And in our CICU is primarily used for patients with cardiogenic shock who are being bridged to more durable therapy, such as transplant or LVAD. It required a 23 French introducer and can only be placed by cardiac surgery via axillary cut down, meaning that the implantation requires more coordination and planning than that of the CP in the cath lab. It does provide higher support though, with flows up to 6 liters a minute, and it contains a motor, outlet, and inlet, but it does not have a pigtail. And the ability to implant the 5.5 in the axillary artery is its biggest benefit because it allows increased patient mobility. So in our CICU, these patients are actually able to walk with the device in place to maintain strength and conditioning. This is an example of the Impella CP driving console. So the top graph shows an arterial pressure tracing obtained from an outlet pressure sensor in the ascending aorta, as well as the left ventricular pressure tracing obtained from an inlet pressure sensor in the left ventricle. The P5 you see at the top right is the flow setting, which the user can manually change to increase the speed of the rotor and provide more or less flow. And there are 9 gradations, so P9 would be the highest amount of support that the device can give. The bottom graph represents the calculated motor current. The bottom left box shows the calculated flow provided by the Impella. The bottom middle table provides information about the purge system, which is a component of the Impella that requires either a heparin, bicarbonate, or bivalirudin solution that creates a pressure barrier, which prevents the blood from entering the motor housing. And then the cardiac output in the bottom right box actually has to be either entered manually or is calculated by the device if hemoglobin is included. Following FDA approval of the Impella, there was a dramatic uptake in utilization across the United States. So these figures from a retrospective register study, which used the premier healthcare database and examined 48,000 patients who underwent PCI with mechanical circulatory support from 2004 to 2016. So this bar graph on the left shows that Impella use in that time span increased about 5-fold. And then in the figure on the right, we can see that there was a lot of variation across hospitals. The x-axis represents hospitals arranged in order of increasing Impella use, and the inset shows the estimated mean odds ratio. The mean odds ratio was 5.8, indicating that statistically identical patients had a greater than 5-fold differing likelihood of receiving Impella at one randomly selected hospital in comparison to another. There was a greater than 2.5-fold variation in other outcomes such as bleeding and greater than 1.5-fold variation in death, AKI, and stroke. Adverse outcomes and costs were also higher in the Impella group, particularly in hospitals with higher Impella use. And finally, Impella use was associated with a higher odds of death or bleeding. These types of findings and the rapid uptake of Impella devices raised questions about whether there was strong enough evidence to support their use. This figure nicely summarizes indications for use of these flow pumps as well as their relevant RCTs. So we're going to discuss trials for high-risk PCI, acute MI complicated by cardiogenic shock, and left ventricular unloading. And as a side note, left ventricular unloading and renal protection are not currently FDA-approved indications for use of Impella. Let's take a look at acute myocardial infarction and cardiogenic shock. So we already discussed the ICER shock trial, for which I would argue the results were somewhat underwhelming, even though it led to FDA approval. So another trial that examined this population was IMPRESS. IMPRESS was a randomized open-label prospective multi-center trial which enrolled 48 patients with severe cardiogenic shock complicating acute MI. The trial investigators wanted to select for a sicker population, so they required the participants be mechanically ventilated. Participants were randomized to balloon pump or Impella CP, and the primary outcome was 30-day all-cause mortality, with 6-month mortality being a secondary outcome. Overall, this was a very sick population, with 92% of patients experiencing cardiac arrest prior to randomization, and almost 1/2 had greater than 20 minutes of time to ROSC. The Kaplan-Meier curve on the right shows that the mortality was similar between the two groups at 30 days and also at 6 months. And of note, bleeding was also more common in the Impella group, occurring in 1/3 of the Impella patient. So as with ICER and shock, the issues with this study was the small sample size and also the inadequate powering, which significantly limited interpretation of the results. So next, we're going to talk about the evidence for the use of microaxial flow pumps in high-risk PCI. And so the main relevant trial in this case is PROTECT-2. PROTECT-2 was a prospective randomized multicenter trial conducted in 112 sites across the US, Canada, and Europe. It enrolled 452 patients with 3 vessel CAD or unprotected left main disease and depressed ejection fraction, and randomized them to either balloon pump or Impella 2.5 during non-emergent high-risk PCI. The primary endpoint was 30-day incidence of major adverse events, and a 90-day follow-up was required as well. The figure at the bottom shows the Kaplan-Meier curve for the intent to treat population, which is on the left, and for the per protocol population, which is on the right. There was no significant difference in the primary endpoint at 30 days between the two groups. However, there was a trend towards a lower risk of adverse events in the intent to treat population at 90 days, as seen by the separation of the curves there. And then there was also a significant difference in adverse events in the per protocol population at 90 days, as seen on the right. There were a few limitations here, the biggest one being that the trial was actually stopped early due to futility based on a conditional power cutoff that they had established of 40%. And so the trial actually only received 69% of its planned enrollment and was not sufficiently powered. And because the difference in the 30-day events did not reach statistical significance, the analysis for the 90-day events was considered exploratory only. Finally, given the different radiographic appearance of balloon pump and Impella, operators were not blinded to treatment assignment. Next, we'll discuss the existing evidence for the role of microaxial flow pumps in left ventricular unloading. So there was a multi-center prospective randomized exploratory safety and feasibility trial called DTU in STEMI. It randomized 50 patients with anterior STEMI but without cardiogenic shock to LV unloading via Impella CP, followed by immediate reperfusion versus delaying reperfusion until 30 minutes after unloading. The primary safety outcome was a composite of major adverse events at 30 days. The efficacy parameter, infarct size, was calculated using cardiac MRI. And here, the major adverse event rates were not significantly different between the immediate reperfusion and delayed reperfusion groups. Infarct size was also not affected by delaying reperfusion. And so the conclusion here was that it seemed feasible to continue to study whether LV unloading prior to restoring coronary perfusion in STEMI had clinical benefit. However, since this was a very small pilot study, more rigorous RCTs are needed in this space. And so based on what we've seen so far, you may think that the evidence base for using these devices is rather limited. A number of studies leveraged clinical registries and insurance claims databases to provide real-world observational evidence. This figure is taken from a study actually published by the core group here at Yale in 2020. This was a propensity-matched, registry-based retrospective cohort study of 28,000 patients with acute MI complicated by cardiogenic shock undergoing PCI. And data was obtained from multiple ACC and CDR registries. Patients receiving microaxial flow pump were matched with those receiving balloon pump, and among 1680 propensity matched pairs, there was a higher risk of in-hospital death associated with microaxial flow pump use, thus favoring balloon pump use. And there was also a higher risk of major bleeding with microaxial flow pump use. An additional retrospective propensity match cohort study led by Dr. Miller used administrative claims data for 3,000 commercially insured patients from 14 states across the US and examined those who underwent PCI for acute MI complicated by cardiogenic shock. Patients receiving Impella were matched to similar patients receiving balloon pump again. And among 817 propensity matched pairs, intravascular flow pump use was associated with higher 30-day, 1-year mortality and bleeding dialysis, as well as higher costs, and again favored use of balloon pump. Taken together, these observational studies and the lack of high-quality RCTs raise further concerns about whether microaxial flow pumps actually improved clinical outcomes and whether the risks of complications such as bleeding might outweigh the benefits. So it was in this setting that the Danger Shock trial was conducted. It enrolled 360 patients with STEMI and cardiogenic shock at 14 centers in Europe and assigned them to Impella CP plus standard care or standard care alone. The study excluded patients who experienced out-of-hospital cardiac arrest and those that remained comatose, as well as those with RV failure. The primary outcome was 180-day all-cause mortality. As you can see in the figure on the bottom left, there was a significantly lower risk of death at 180 days in the Impella group, with a mortality rate of 45.8% and then 58.5% mortality rate in the standard care group. The overall hazard ratio was 0.74 in favor of Impella use. The Kaplan-Meier curve of the time of death on the top right showed early separation of the curves, which persisted for the primary outcome. And so these findings were particularly notable because this was the first time that use of this device has been shown to be associated with lower mortality than standard care, which contradicts the results of previous RCTs and also observational studies we've discussed today. These positive findings did come at a cost. There was a higher incidence of complications in the Impella group, in particular major bleeding and renal replacement therapy. This suggests that though there may be benefit to the use of Impella, appropriate patient selection is critical to minimizing poor outcomes. Danger shock also had a number of limitations. First, the trial took 10 years to enroll patients. Second, it excluded comatose patients, thus ensuring that it selected less sick patients and ensured that those patients had a better chance of neurological recovery. Third, there was a higher incidence of complications with Impella despite improved mortality, which we discussed. And then most notably, there was an unusually high mortality rate in the standard care group of 60%, which is higher than the 40 to 50% rate that I quoted you in the beginning of this presentation. And so the figure at the bottom is actually from a subgroup analysis in the same paper of the primary outcome by country of enrollment. The top line shows that for patients enrolled in Denmark, mortality rate for the standard care group was 64%. But the mortality rate for patients enrolled in Germany and UK, shown in the second line, was 49%, which is more in line with what we've traditionally known. And so this suggests that there may be something different about this population enrolled in the standard care group in Denmark, which potentially could have affected the results. And finally, to further hammer home the point about the importance of patient selection, earlier this year, an exploratory secondary analysis stratifying danger shock participants by age group was published. So it showed that for patients less than 77 years old, 180-day all-cause mortality was lower in the microaxial flow pump group. But for patients aged 77 years or older, there was no significant difference between the treatment groups. The figure on the top right shows that inflection point at 77 years old. And so this suggests that Impella use perhaps might be more favorable in younger patients, whereas standard care might be more favorable in older patients. There were, in this case, no significant differences in complications by age, just the mortality outcome. And so I think this is added evidence that we have to be very careful when we select these devices in terms of which patients to apply them to. Despite some of its limitations, the findings from danger shock directly contributed to changes in recommendations from the 2025 ACC AHA guidelines for management of acute coronary syndrome that were actually just published. So in patients with STEMI and cardiogenic shock, use of a microaxial flow pump is now given a class 2A recommendation, whereas use of a balloon pump and VA ECMO in the same population is given a class 3 recommendation. So no doubt, this is going to significantly shape the management of these patients in the years to come. One device we haven't talked about that much is Impella 5.5. Unfortunately, there are no randomized clinical trials of this that have been published thus far. Overall, its use seems to be increasing, particularly in transplant centers. This observational study used data from the multi-center SURPASS registry of patients with cardiogenic shock receiving Impella, and it included 444 patients with cardiogenic shock due to heart failure. And the figure, which in my opinion is a little bit hard to interpret, describes their outcomes. The mean duration of Impella support was 21 days, longer than the 14-day approved FDA-approved duration. 75% survived to discharge, with 71% surviving to 6 months and 64% surviving to 12 months. And so the authors here concluded that this was a relatively favorable survival rate for a very sick population, both as a bridge to what they called native heart survival and also heart replacement therapy, meaning transplant or durable LVAD. So where do we go from here? Prior to the publication of danger shock, there were additional rigorous RCTs such as Recovery 4 that were underway to compare microaxial flow pump use and standard care. However, given the positive findings of danger shock, this trial was actually stopped as there was no longer clinical equipoise. Given the limitations of danger shock, I think future studies can be more focused around determining appropriate selection criteria for patients most likely to benefit from microaxial flow pump. We are still awaiting RCTs of Impella 5.5, and we should also expect to see more rigorous studies looking at combined use of microaxial flow pump and other forms of MCS. And finally, there's work ongoing to develop strategies to mitigate adverse events such as bleeding. And so with that in mind, there are actually new devices in the pipeline that are being studied. These new devices are called Impella ECP on the top left, Sapira on the top right, Magenta Elevate on the bottom left, and Vitalist in the bottom right. They all pump blood from the left ventricle into the aorta. All are able to augment cardiac output and are inserted via femoral access. And 3 of the devices are inserted through smaller introducer sheaths than the current Impella CP and contain a pump that expands after it's unsheathed in the aorta. The Impella ECP and the Magenta Elevate are the ones that are the furthest along in their development. The ECP uses a 9 French introducer sheath, but has a 21 French pump that is compressed to 9 French for insertion and removal, and the pump expands after it's unsheathed in the aorta. The ECP pivotal study was a prospective multi-center single-arm study looking to demonstrate that Impella ECP use was safe in high-risk PCI. The primary endpoint was a 30-day adverse event rate, which was compared to a predefined performance goal. And the final results of the study, which have not been published yet, this is just from the Impella website, show that the 30-day event rate was 6.3%, which was below their own predefined performance goal of 24%. The bleeding rate was 5.9%, and so their conclusion at this point is that they feel the device is safe to continue to study in humans. Meanwhile, the Magenta Elevate, which also uses a smaller introducer and has a pump that expands in the aorta, just like the ECP, was investigated in this first-in-human study in 14 patients who underwent high-risk PCI. There were no major device-related adverse events, just 1 hematoma, and none of the patients died within the first 30 days. So in summary, percutaneous microaxial flow pump use has dramatically increased in the past 20 years. There was limited evidence showing that this device improved clinical outcomes until last year with danger shock. And current approved indications for use of these devices includes acute myocardial infarction and cardiogenic shock, high-risk PCI, CABG, and for Impella 5.5 cardiogenic shock. More rigorous RCTs are needed to better understand the impact of these devices on clinical outcomes. And so in this vein, new devices are in development to help mitigate the risks of complications. And finally, more work needs to be done to optimize selection of patients who may benefit the most from the use of these devices. I'd like to thank my primary faculty mentor, not just for this talk, but also for my career, Dr. Elliott Miller. And I also would like to thank Dr. Ali and Dr. Farrington for additional feedback. And finally, I'd like to thank the Yale Cardiology Fellowship Program.
All right, so I am delighted to introduce Christine Shui as one of today's Grand Master speakers this afternoon. Christine graduated from Wesleyan University with a BA in chemistry before attending Albert Einstein College of Medicine. She next completed internal medicine residency here at Yale, where she served as chief resident during the 2021-2022 academic year. She's excelled during her cardiology fellowship, pursuing advanced training in both echocardiography and cardioobstetrics. Additionally, during her time as a clinical fellow, she's honed her teaching skills and passion for medical education. As a fellow and training representative at the American College of Cardiology Educator Fundamental Skills Conference, as well as serving on the education committee for the Connecticut chapter of ACC. I've had the pleasure of serving as Christine's clinical mentor this year as she's trained in cardioobstetrics, and I'm so excited that she's chosen this career path and that she'll be joining faculty this fall as a general cardiologist and cardioobstetrics specialist. Today, she's going to be talking about what all of us as cardiologists should know about hypertensive disorders of pregnancy. So congratulations, Christine.
Thanks, everyone. I'm grateful to say that my topic won't overlap very much with Anju's, but I'm thrilled to be presenting with him. And so I chose to talk about hypertensive disorders of pregnancy because it encapsulates my interest in the dynamic changes that occur during pregnancy, as well as highlighting importance of longitudinal care in general cardiology. And so in the last 3 years, I've had the pleasure of working with Dr. Stotts and Dr. Goldstein, who are my main mentors for this talk. So any disclosures. So like Dr. Goldstein was mentioning, my goal is to review what us general cardiologists should understand about these disorders. And so first we'll define hypertensive disorders of pregnancy, which we'll shorten as HTP because it's a mouthful. Second, we'll identify the immediate long-term impact on cardiovascular outcomes. Third, we'll talk about the management of HTP briefly. And lastly, we'll review the resources here at Yale that are available for patients with HTP. And so first, hypertensive disorders of pregnancy are diagnosed when blood pressures are above 140 or over 90 in terms of diastolic blood pressure. Chronic hypertension is diagnosed when patients develop these elevated blood pressures before 20 weeks gestation and or if they persist after 12 weeks postpartum. Gestational hypertension is solely during pregnancy, and so it's diagnosed if blood pressures are elevated after 20 weeks of gestation and it resolves before 12 weeks after delivery. Preeclampsia develops after 20 weeks and in the immediate postpartum period and is defined as an acute rise in blood pressure associated with proteinuria. Severe features of preeclampsia include severe range blood pressures above 160 over 110, thrombocytopenia, transaminitis, AKI, or acute kidney injury, abdominal pain, visual changes, and pulmonary edema. HELP is a severe preeclampsia variant and stands for hemolysis, elevated liver enzymes, and a low platelet count. Eclampsia is when new onset seizures develop without an alternative etiology in the setting of HCP. And it's important also to note that it's very common to develop superimposed preeclampsia. In 20 to 50% of women with chronic hypertension and up to 50% of women with gestational hypertension, they develop superimposed preeclampsia. However, unfortunately, this does not usually progress in a linear fashion, and so patients can present for the first time with severe preeclampsia. It's also important for us to highlight that this can present for the first time in the immediate postpartum period, particularly because 60% of deaths due to HCP occur within the first week after delivery. So preeclampsia can be further stratified based on its onset. Well, in see it, I'll use echo and uterine artery Doppler to assess the hemodynamics of patients who develop early versus late onset preeclampsia. Early onset, being less than 34 weeks gestation, was associated with worse maternal and perinatal outcomes. These patients usually had a lower BMI, were over the age of 35 years old, and on uterine artery Doppler evaluation, there is usually notching of the uterine artery and fetal growth restriction. On echo, they found these patients had low cardiac output, high SVR, and a decreased intravascular volume. In contrast, patients who developed late onset preeclampsia, defined as after 34 weeks, had higher BMI and normal fetal growth, and they were not noted to have notching of the uterine artery. On echo, they were noted to have high cardiac output, low SVR, and increased intravascular volume. There's multiple risk factors for preeclampsia, many of which overlap with the traditional risk factors of cardiovascular disease. These include diabetes, obesity, kidney disease, autoimmune disease, history of chronic hypertension, hypertensive disorders of pregnancy, sedentary lifestyle, age greater than 35 years old, Black race, and coarctation of the aorta. There's also multiple pregnancy-specific risk factors, including multiparity, first pregnancy, and in vitro fertilization, particularly with a donor egg. Lastly, genetic risk scores associated with HCP have been identified, but routine genotyping to calculate risk of HCP has not yet been incorporated in clinical practice. The mechanism of preeclampsia is not yet fully elucidated, but this figure illustrates the complexity in its pathogenesis. First, acquired genetic and immune risk factors are contributors to abnormal placental development. Normally, the diameter of the uterine spiral arteries increase and there's remodeling of the endothelium and smooth muscle. However, this doesn't occur in preeclampsia, and abnormal placentation results in decreased uteroplacental perfusion. Subsequently, there's an increase in inflammatory and antiogenic biomarkers, resulting in endothelial dysfunction in a pro-inflammatory state. The downstream effects of these impact the brain, liver, heart, kidneys, and hematologic balance. Looking at the outcome of HDP, we can start based on a population level. The United States has a high maternal mortality ratio compared to other higher income countries. When stratified by race, you see an exceptionally increased maternal mortality ratio in American Black women compared to all American women, as well as Asian, Hispanic, and white women counterparts. And chronic hypertension has also been rising in our pregnant women population. In the United States, cardiac disease is the leading cause of maternal mortality, with 7% of deaths directly related to HCP. Coronary disease, cardiomyopathy, and stroke are significantly associated with HCP and account for many of pregnancy-related deaths as well. Globally, hypertension is the second most common cause of maternal death after hemorrhage. HCP is the most frequent cause of postpartum readmissions and impacts 16% of delivery admissions in the United States. It's associated with increased rates of placental abruption, postpartum hemorrhage, and preterm delivery. Additionally, it's associated with poor fetal and neonatal outcomes, including neonates that are small for gestational age and stillbirth. The prevalence of HCP varies widely just based on race, ethnicity, and socioeconomic status. Black, Native American, and Alaska Native women have the highest prevalence of HCP. Preeclampsia-related mortality is 2.7 times higher in Black women compared to white women, and 1 in 5 delivery hospitalizations among Black women are associated with HCP. Based on CDC data from 2022, we note that the prevalence of HCP has been found to be higher in rural areas, lower income areas, and in the South and Midwest census regions. HCP is associated with an increased immediate risk of mortality, MI, stroke, pericardial cardiomyopathy, and SCAD. The risk of developing these major adverse cardiac events is dependent on the type of HCP, the risk highest being in patients with a history of preeclampsia and preeclampsia superimposed on chronic hypertension. Hypertensive disorders of pregnancy are also strong risk factors for pericardial cardiomyopathy, pregnancy-associated SCAD, and pregnancy-associated heart failure with preserved ejection fraction. Long-term, HCP is associated with a 2 to 4-fold risk of the development of chronic hypertension 10 to 20 years after delivery. It's additionally associated with increased rates of diabetes, obesity, and hyperlipidemia. Long-term, it's also associated with twice the risk of ischemic heart disease, stroke, and venous thromboembolic events 5 to 15 years after pregnancy. While this may in part be due to shared risk factors, some studies have additionally demonstrated preeclampsia as an independent risk factor. Many hypothesize that this is due to accelerated vascular aging in these patients. One study I wanted to highlight is this one by Honenberg et al., which looked at a UK biobank of 220,000 women, ages 40 to 69 years old, with at least one live birth. And they looked at the prevalence of cardiovascular disease in this population. They found significantly higher rates of chronic hypertension in patients with a history of HCP, which are the red bars, and a higher absolute blood pressure in this population, even after adjusting for age and antihypertensive use. They additionally found higher rates of hyperlipidemia, diabetes, and CKD in patients with a history of HCP. Patients with a history of HCP were noted to have increased incidences of cardiovascular conditions in age groups below the age of 65. They also noticed increased rates of coronary disease, heart failure, aortic stenosis, and mitral regurgitation. In causal mediation analysis, chronic hypertension only explains 64% of HCP's association with coronary disease and 49% of HCP's association with heart failure. Thus, the development of chronic hypertension after HCP explains some, but not all, of the increased rates of these cardiovascular outcomes. The long-term impact of preeclampsia can be seen on the routine imaging studies that we use in cardiology. Benskop et al. Compared coronary calcium scores in women ages 40 to 63 years old with and without a history of preeclampsia. Women with a history of preeclampsia were more likely to have coronary calcium compared to those without, even after adjusting for smoking history, BMI, diabetes, hypertension, hyperlipidemia. Coronary calcium developed on average 5 years earlier compared to their counterparts in patients with a history of preeclampsia. In patients with a history of preeclampsia, the likelihood of developing coronary calcium significantly increased in the 40 to 50-year-old age group compared to the 40 to 45-year-old age group, suggested that women with a history of preeclampsia should undergo aggressive cardiovascular risk factor modification before age 45 and the onset of disease. Left ventricular remodeling can occur during normal pregnancy, but this resolves after delivery. The study by Contreras et al. In 2021 assessed the echoes of patients 8 to 10 years after delivery. And they found that a history of HCP was associated with increased interventricular septal wall thickness compared to patients who had a normotensive pregnancy after adjustment for age, race, hypertension, placental vascular malformations, BMI, and hemoglobin A1C. Patients with a history of both HCP and current hypertension had thicker interventricular wall thickness, increased LV wall remodeling, and decreased mitral inflow, suggested that the 2 hits of HCP and current hypertension have the largest effect on left ventricular changes. Notably, the average age of patients enrolled in the study was just 39 years old. Now that we've discussed LV remodeling in HCP, we can review the clinical impact that this has. Williams et al. Conducted a retrospective cohort study to assess the primary outcome of hospitalization of HFpEF after delivery complicated by preeclampsia or eclampsia. Utilizing the New York and Florida statewide inpatient databases, a total of 2.5 million women were included in this study, 5% of whom had a history of preeclampsia or eclampsia. They excluded patients with a history of chronic kidney disease, lupus, ischemic heart disease, PE, and pre-existing heart failure to reduce the risk of a confounding cause. And they found that women with a history of preeclampsia, eclampsia were at increased risk of hospitalization for heart failure. And more specifically, additionally, heart failure with reduced ejection fraction, both within the first 90 days of delivery and the 10 years after delivery. Median time to onset of any heart failure hospitalization from delivery was just 20 months, and the median age of diagnosis was 33 years old. And in terms of their primary outcome, a history of preeclampsia, eclampsia was independently associated with increased risks of HFpEF hospitalization, with a median time to onset of 32 months and a median age of diagnosis of 34 years. After adjusting for baseline hypertension and covariates, the hazard ratio for the development of HFpEF after having a diagnosis of preeclampsia, eclampsia was 2. So because of all of this data that we have on the adverse impact of HDP on cardiovascular outcomes, it's critical for us as cardiologists to solicit a thorough reproductive history for cardiac risk stratification as recommended by ACC and AHA guidelines. Next, we'll look at the management of HDP. And so even though it's very important for us to understand our patients' clinical courses, the management is largely guided by our obstetrician colleagues. Decision-making surrounding antihypertensives becomes particularly nuanced in the 3rd trimester due to the concern that initiating or up-titrating antihypertensives can mask preeclampsia with severe features. And so I go over this management with a caveat. So in terms of preeclampsia risk reduction, moderate exercise is associated with a 40% risk reduction in preeclampsia. And it serves as an opportunity for us to counsel our patients, most of whom are all at high risk of HDP, to start an exercise routine prior to conception that can be continued during pregnancy. For at-risk patients, initiating aspirin between 12 to 16 weeks gestation decreases the risk of preeclampsia and adverse outcomes by 60%. This is thought to be due to inhibition of COX-1 and COX-2, which contribute to prostaglandin synthesis and endothelial dysfunction. Calcium supplementation is not yet included in the American guidelines, but it's been found to reduce preeclampsia in women with a history of a low baseline calcium intake. And it's thought that hypocalcemia can stimulate parathyroid hormone or renin release, increasing intracellular calcium and causing vasoconstriction. And time to birth, again, guided by our obstetrician colleagues, has been found to have a decrease in rates of preeclampsia. There's concern that lowering maternal blood pressure too much can compromise the uteroplacental circulation and fetal growth. The CHAP trial, which was the chronic hypertension in pregnancy trial, was a multi-center open label one that randomized pregnant women with a history of chronic hypertension into 2 groups, either with a blood pressure goal of less than 160/105 versus less than 140/90. They looked at 2,400 women in this study and found that patients with a lower blood pressure goal were found to have a lower composite outcome of preeclampsia with severe features, preterm birth, placental abruption, and fetal neonatal death. They did not find any difference in fetal growth restriction with either the lower versus higher blood pressure cutoffs. The American College of Obstetricians and Gynecologists, which we'll shorten as ACOG, recommend initiating antihypertensive therapy based on this study in patients with a history of chronic hypertension if their blood pressures are over 140/90. In women with a history of gestational hypertension or preeclampsia, the blood pressure cutoff is higher. So initiating of antihypertensives if blood pressure is over 160/110. However, blood pressure treatment thresholds vary among societies, and some have come out with these guidelines before CHAP trial came out. So for management of HDP, again, a lot of these medications are initiated and titrated by our obstetrician colleagues. The first-line therapies that are often used are labetalol and nifedipine. However, adjunct therapies with methyldopa, hydrochlorothiazide, and hydralazine can be used. Of note, we commonly use as cardiologists ACEs and ARBs and MRAs, but this is not used antepartum as they cross the placenta and impact fetal development. However, postpartum enalapril can be used and is safe in breastfeeding. In severe hypertension, IV labetalol, hydralazine, and nitroglycerin can be used, and magnesium is used for a seizure prophylaxis. Ultimately, the HDP antepartum is managed with delivery of the placenta. One of the questions patients usually ask us in our postpartum clinic is what having preeclampsia means for their future pregnancies. The risk is lower in subsequent pregnancies with the same partner, but it's still higher compared to the general population. The risk is particularly higher if preeclampsia onset is before 37 weeks of gestation. Optimizing blood pressure before and during pregnancy can reduce the risk of preeclampsia. And so oftentimes our goal when we counsel patients is less than 140/90 before conception and in the first trimester. We recommend 2 to 3 months of stable blood pressures below this goal before trying to conceive. Family planning contraception are discussed at our visits because it influences the antihypertensives that we use. Additionally, there's an increased risk for recurrent preeclampsia with short interval pregnancies, so less than 6 months between birth and conception. And so we recommend avoiding any unplanned pregnancies as we optimize blood pressure and cardiometabolic risk factors. Combined oral estrogen and progestin, oral hormonal contraception increases blood pressures, and so there's an absolute contraindication for use of these in patients with uncontrolled blood pressures. So lastly, we'll review the resources available at Yale. Post follow-up is critical for this patient group, given as we've covered the high risk of morbidity and mortality in the immediate postpartum period. ACOG guidelines recommend that patients with a history of HTP have their blood pressure evaluated within 7 to 10 days of delivery. And if patients have a severe hypertension, they should be evaluated within 72 hours. Additionally, it's recommended that women with a history of preeclampsia undergo a comprehensive cardiovascular risk assessment within 6 to 12 weeks of delivery. However, more than 40% of women don't attend a postpartum visit by 6 weeks. 50% of women do not see a longitudinal clinician, such as a primary care provider, within 6 months. And lastly, despite the increased risk of hypertension, less than 1/3 of patients have a blood pressure check 1 year postpartum. Given the high prevalence of HTP and significantly increased risk of morbidity and mortality, there's increasing emphasis on establishing multidisciplinary postpartum hypertension clinics to facilitate close follow-up and transitions of care. And so this picture is from the most recent ACC toolkit on how to develop a postpartum hypertension clinic, but we've been fortunate at Yale to have these resources already. So the Maternal InReach Team for Equity, shortened as MIGHTY, is a postpartum blood pressure program which was developed by cardiology and obstetrics. HTP patients are identified by the obstetrics team during their delivery admission, and they're provided blood pressure monitors and closely followed by the obstetrician and pharmacy team for blood pressure monitoring and titration of antihypertensives for up to 12 weeks after delivery. High-risk patients are referred to postpartum hypertensive disorders of pregnancy program in cardiology. And so this postpartum follow-up is an opportunity for us to mitigate a woman's future cardiovascular risk, especially because for a lot of women, pregnancy can be the first time in their adult lives that they interact with healthcare providers. We work closely with nutritionists, exercise physiologists, and pharmacists, given that exercise, weight management, and blood pressure optimization are associated with a reduced risk of preeclampsia. In the clinic visit, we do a thorough cardiovascular risk factor assessment, including an in-depth family and social history, assessment of life's essential aid to identify modifiable cardiovascular risk factors, and order cardiometabolic testing with a hemoglobin A1C, lipid panel, and lipoprotein (a). Given cholesterol levels are increased during pregnancy, we defer lipid screening until at least 6 months postpartum, particularly if the patient is breastfeeding, as this can impact lipid levels as well. Patients identified at high cardiovascular risk, such as an abnormally high lipoprotein lipid A, can be further referred to preventive cardiology for further evaluation. We also refer many patients to primary care to help establish longitudinal follow-up, and we discuss the benefits of breastfeeding with patients as it's associated with lower rates of maternal hypertension, hyperlipidemia, insulin resistance, and refer them to lactation if they have additional challenges and concerns breastfeeding. We also review our recommendations for contraception methods and refer them to family planning for additional follow-up. So in summary, for my takeaways, hypertensive disorders of pregnancy encompasses chronic hypertension, gestational hypertension, preeclampsia, and eclampsia. Patients with HTP are at higher risk of developing early onset cardiovascular disease. And when a pregnancy is complicated by HTP, the healthcare system should aim to help patients become more engaged in cardiovascular prevention. Treatments recommended for blood pressures over 140/90 in patients with a history of chronic hypertension and over 160/110 in gestational hypertension and preeclampsia. Close multidisciplinary follow-up is needed for optimal blood pressure control and cardiovascular risk screening, which is available at Yale through MIGHTY and the Postpartum Hypertensive Disorders of Pregnancy Clinic. So thank you to Dr. Goldstein for teaching me so much this year about cardiac obstetrics in the postpartum phase. Dr. Sachs, I've learned about general cardiology and hypertension so much in the last 3 years, as well as Dr. Dymo and Maria, without whom our clinic would not function. So thanks. You made it on time.
All right, so we have some time for questions from the audience. I'll start with Andy. So Andy, in the circulatory support, it's kind of a simple question, but there's hemodynamic effects and there are these inflammatory effects as well, right? And I wanted to sort of tease out how much of the deleterious, some of the consequences that you're seeing in these trials are to that balance and are there strategies to sort of optimize sort of the pro-inflammatory states that occur with these circulatory support strategies?
Oh, yeah. Yeah, I'm not sure if we know enough about how much of these outcomes are related to the impact on the inflammatory cascade. I think certainly there is some impact on inflammation from the use of these devices. The biggest problem oftentimes ends up being bleeding, which for the most part, I think is more of a mechanical problem than an inflammatory problem. So I think that tends to be the biggest issue. And then other issues, common issues end up being things like infection, which is just, any device, foreign device being in the body is a high risk for infection. So I'm not entirely certain to what extent the inflammatory response in the body to the devices plays a role. In terms of modifying that response, I wouldn't say, at least in terms of our use of balloon pumps and Impellas, there isn't necessarily a lot that we're doing to mitigate that. I think ECMO is like a little bit different. There's a lot more that goes into regulating it, but yeah, I'm not sure that we're really doing too much to actually stop the negative inflammatory effects of the devices.
Other questions for the audience?
You guys both gave great presentations. So Andy, I have a question. So the clinical trial data of the Impella device, the 2 something version, I mean, it's largely not so impressive, yet it gets a 2A recommendation, which is just kills me, but be it as it may. Is it also just outdated? Like, are you only using the 5 something device now? Because is all of that relevant, or have we moved on and the technology is just developing so fast? How would you propose that, clinical trials keep up with the rate of technology development, given that that seems obsolete now?
Yeah. So the initial FDA approval came with for the Impella 2.5 device, which we actually don't really use now. We only use the CP or the 5.5. The Danger Shock trial, which is the main trial that the ACC/AHA recommendation was based off, is the main factor in that 2A recommendation, and they use specifically the Impella CP. So I'm not sure if there's really a better way besides to continue to do trials as these devices develop. I think that's, as far as I can tell, that seems to be what they're trying to do, since now all these new devices that I mentioned are undergoing feasibility studies. I think for right now, I'm not sure that we necessarily have a better method than doing separate trials of new devices. I think at some point that will get to be too much, and the degree of development is probably only going to increase. But I think the Impella 5.5 in particular, has not really been studied that rigorously, so that's definitely something that needs to be done.
Good.
Great talks, both of you, really clear, and I learned a lot from both of them. So there's a story about soluble FLT1 and PLTF and the ratio of those that, Sarah, and you probably know a lot more about than I do. Soluble FLT1 is anti-angiogenic, and placental growth factor is pro-angiogenic. And it may not be so much about driving the production or the new growth of blood vessels, although that could be part of the story in uterus, but it may just be about triggering nitric oxide production. NO is anti-atherogenic, it's lowers blood pressure actually. So my question is there any story about tracking those ratios in hypertensive disease and pregnancy as a risk or a way to sort of predict the severity of it? I think that's being done a little bit for preeclampsia, right?
It looked like there's like many studies looking at these levels during pregnancy, but I'm not aware of any clinical practice like starting to monitor for patients who are at high risk. Definitely now that we know that there's like a genotype that predisposes patients for HCP, I think that's definitely something that we could start tracking in the future.
Christine, I really enjoyed your presentation, but one thing that struck me was the data about the acceleration of atherosclerosis and coronary calcifications. And so I guess what's our approach going to be? Are we treating every patient who has a hypersensitive disorder of pregnancy or preeclampsia then are they a cardiology patient for life? And what is our approach going to be to their longitudinal clinical care moving forward? What's the optimal screening strategy for that woman who is maybe in her early 30s that develops this disorder?
Yeah, I think that's something that I'm trying to figure out as a clinician in interest in both of these fields. Right now, our current practice is to start with cardiometabolic testing to identify those really high risk patients, especially because our patient volume is just so high that it would be challenging to follow all of them longitudinally. But I agree. I think that as awareness further develops, things like coronary calcium scores can be utilized based on a history of preeclampsia and helps us identify those patients that might benefit from, like statin initiation with like more aggressive goals. But I don't think there's like every patient seeing cardiology longitudinally would be very feasible at this point, given just the predominance of HDP.
But I mean, preeclampsia is on that risk in cancer list, right? It's well established. So if you're adding up the scores, I don't know if it's part of a score calculation, but it's a risk in cancer. I don't know if HDP, it sounds based on your presentation that we should include that as a risk in cancer as well.
Yes, it is included as a risk in cancer.
Sure.
You guys both gave great talks. Congratulations. So I have a question for Christine. We haven't ever talked about this before. So a lot of institutions and hospital systems are not as lucky to have someone like you who can provide this specialized care from within cardiology for these patients who have had hypertensive disorders of pregnancy. Where do you sort of see the future going so that this sort of care can reach as many patients as possible, whether that's through education or advocacy, or how do you feel like we can reach more patients than just the few that we can see in our clinic?
Yeah, for sure. I think this ties in really well to its question about longitudinal follow-up. I think in collaboration with our primary care physicians who oftentimes see these patients more frequently and provide that kind of like initial cardiovascular screening and kind of like increasing awareness about increased cardiovascular risk in the future. Oftentimes with pregnancy and delivery, a lot of these things that are diagnosed can be lost in all the notes that occur. And so we don't really think about the long-term implications of them. And so I think increasing awareness and also just emphasizing that it is a future cardiovascular risk factor is really important in primary care as well.
I have one more question for Andy. As we talk about mechanical circulatory support and Impella usage, one thing that I would like to hear is what's our approach within the Yale CICU to patient selection, and how are we standardizing who we're offering that support to?
That's a good question. I think that is also something that has been changing, at least from what I've experienced from the beginning of my fellowship up until now. I would say that our use of the Impella device has increased in the last few years compared to what we were doing during my first year of fellowship, which was in 2021, 2022. And so even in that not very long time span, we've actually had some change in our practice, and that has been for a number of reasons. One of which is that the Impella 5.5 device has been developed, and so that has become our go-to device for patients who are awaiting destination LVAD or transplant. And that is, I think, something that has certainly become sort of a standard in our CICU, just because those patients can have the device implanted into their axillary artery. They are able to get up and go on daily walks so that they don't get super deconditioned as they're waiting for their eventual surgery. And so I think that, and that is what we have standardized the most, and that's working in conjunction with our heart failure team and the CICU team, and also the cardiac surgery team. The Impella CP, I think that use of that device is a little bit more varied, and some of that has to do also depending on who is using it and what their own experience of the device is. I don't know that we've necessarily just developed a specific protocol for when to implement that one. And sometimes those decisions are also being made potentially, in the middle of the night, when there isn't necessarily a whole team to have a discussion about it. But I think the danger shock trial does bring up this idea of, is with this patient that we're putting this Impella and fit the criteria for that trial, would they actually be enrolled in that study? And so I've seen cases even recently in the CICU where the Impella was used, which seemed reasonable based on that specific context of that patient, but technically that patient would not have been enrolled in danger shock because they experienced cardiac arrest and were comatose. So we haven't quite, I think, gotten to the point of standardizing that.
Seems like a good opportunity.
Definitely.
Other questions? I'd like to congratulate both of you. You're really outstanding presentations. Great job. Thank you so much.